So, good afternoon, everybody, and thank you so much for joining this webinar. Today is World Sickle Cell Day, and we are here to discuss one of the, one of the issues that has got to do with sickle cell disease at this time in Ghana. So thank you all for joining. We want to know where you are joining from. So if you can please get to the question and answers or the chat and put in probably your name and where you are joining us from so that we can acknowledge you appropriately. Now, before we start anything, I want to use this opportunity to thank my Vice Chancellor, Professor Lydia Aziato. I also want to thank my Dean, the Dean of Fred N. Binka School of Public Health, for giving me and for giving the UHAS community this opportunity for us to have this webinar at this time. So we want to thank them so much. We also want to thank you for making time to come and join us today. Now, before we start, I would like to acknowledge our sponsors. We know that we cannot do anything without funding. So I would like to acknowledge our sponsors accordingly. I would like to acknowledge Bank of Ghana for continuously supporting us, that's the Fred N. Binka School of Public Health, in our advocacy activities. I also want to thank Novartis for supporting this World Sickle Cell Day activities. I also want to thank Solar Nitro Ghana for supporting us. I also want to thank the Volta Regional Hospital for supporting us. I also want to thank the Ghana Medical Association for supporting us. And we know that we have a lot of collaborators in Volta region or the tertiary institutions, and I will do that accordingly as we move on. So today we want to talk about a very pertinent, issue that's got to do with hydroxyurea. And for history's sake, let me talk a little bit about hydroxyurea. Hydroxyurea was approved in the US about 3 decades ago. But then in Ghana, our Food and Drug Administration approved it to be used in Ghana in 2018. And thankfully in 2019, with the help of Novartis and Sickle Cell Foundation Ghana, there was a free rollout. So a lot of sickle cell patients got hydroxyurea for free for 2 years. So when the 2 years ended, there was a gap. Then government came in and put it on NHIS. That means that any patient who has health insurance is supposed to have hydroxyurea for free because it is on NHIS. So, but then we realized that with the first rollout, there were some challenges with it. So there's the need for us to take a look at whether those challenges still exist and how we can help mitigate those challenges so that patients can have access to hydroxyurea, because hydroxyurea has been found to be so helpful, beneficial for sickle cell patients. So today, we want to discuss the state of hydroxy use in the management of sickle cell disease in Ghana, whether there are challenges and the way forward. And because of that, I have a lot of panelists here today. and I know each and every one of them because I've been in advocacy for a very long time. And before I start, let me introduce myself. So I'm Dr. Mary Kwiampoma. I am a clinical psychologist, but at the School of Public Health, that's Fred N. Binka School of Public Health, UHAS, that's the University of Health and Allied Sciences. But I've been in sickle cell advocacy for the past 13 years. So I've done advocacy in Ghana. I've done advocacy globally. I was the CEO stroke president for the Global Alliance of Sickle Cell Disease Organization, headquarters Canada. That was from 2021 to 2022 May. So I have done advocacy globally too. So and I've been in sickle cell advocacy for 13 good years. So we want to discuss this topic. And as I said, we have here Dr. Koku H. Amega Aho, who is a consultant pediatrician and oncologist, and he is the head of department for Department of Pediatrics and Child Health, School of Medicine, University of Health and Allied Sciences. I also have with me Dinah. Dinah is a nurse and also a nurse, a hematology specialist, a nurse who is a hematology specialist at the child health unit at Kolebu Teaching Hospital. I also have Victoria Awo. Awo is an advocate for sickle cell disease. He is the president of the Sickle Cell Association Ghana chapter of the Ridge Hospital. And also she is a caregiver. She has an adolescent who lives with sickle cell disease. Then we have Dr. Ebenezer Wiafi, who is a pharmacist. So he's a provider. So he will speak to being a provider. And he also is a pharmacist at the whole teaching hospital. Then we have Elisa Palmer. Elisa Palmer is a patient. I don't know if they are here, but then we can start with Koku. So Koku is going to give us, Dr. Koku Amegaho is going to give us a presentation on the state of hydroxyurea use in the management of sickle cell disease in Ghana, challenges and the way forward. Then from there, we can have that interaction. You have the opportunity of seeing all our panelists as we interact. So thank you so much. So Dr. Koku Amegaho, can you share your screen so that you can start? Thank you so much. So if you have any questions, I will urge you to put it in the question and answers. When we are done, we will take a look at it. Koku, before you come on, I want to acknowledge some people. I want to acknowledge Dr. Benfo from London. We have Benedicta Buntu from Ho. We have a few people. We have Atole from Ghana, Upper West Region, Jirapa. So keep on letting us know where you are coming from, and I'll take the opportunity to acknowledge you appropriately. Some people said they can't hear. Can you hear now? Can you hear now? The chat option has been disabled. Okay, we would enable it, but you can put your questions in the questions and answers too. Okay. All right. Thank you so much. So, Dr. Koku Amegaho, over to you. Thank you.
Thank you, Mary. Thank you. Good afternoon, everyone. I'm just going to share my screen in a second. Okay, so it's an honor for me to be part of this panel discussion. I'm just going to give us some brief about what we know so far, and I hope that that can help us in continue for this webinar. So, what is this going on? Just a minute. Okay, so my disclaimer, because we'll be talking about hydroxyurea, we know that one brand that is on the market is by Novartis, and I benefited from a global health fellowship at Novartis, but it does not mean that I work for Novartis. I just wanted to disclose that. So where can sickle cell disease be found? Sickle cell disease now is a global problem, and it's as a result of migrations all over, but you can see with this chart that sickle cell disease is more prevalent in sub-Saharan Africa, but you can also see it around the Mediterranean region, India, and a part of Americas. So what are the type of sickle cell disease? We have many types. We have the hemoglobin SS, which we also call, which is also known as sickle cell anemia. We have hemoglobin SC. We have the S-beta thalassemia. There are different forms of that, and there are other type of hemoglobins that cause sickle cell disease as well. But the most severe forms are the SS and the S-beta 0 thalassemia. And how do you get sickle cell disease? It's not an infection, it's something you get from your parent. So assuming that both of your parents have traits, ASAS, then you can imagine that for each of your pregnancy, you have a 25% chance that the baby that will be born from that pregnancy will have sickle cell anemia SS, while some will be having traits and others not at all. So how do we get to understand why sickle cell disease is a big problem and causes so much pain? I don't want to bore us too much, but it's just like normally our red blood cells just look around like donut, and when they don't have enough oxygen, when they have enough oxygen, they squeeze and go through the vessels, what we call the pipes, then to deliver that oxygen. But in sickle cell red cell, what happens is that once they deliver that oxygen or they don't have enough oxygen, they change shape and they find it difficult to regain their original shape. And because of that change in shape, they can block the pipes, the vessels, and because of the lack of oxygen, you can imagine that those parts of the body that will lack the oxygen will be in pain. That's what usually causes the pain. But in addition, other issues also happen, and that lead to certain organs being damaged. Basically, that's what happens in sickle cell disease. So sickle cell disease affects the whole body from head to toe. So it can affect the brain, right? And it can affect the eyes. It can affect the lungs, the heart, the liver, the spleen, the kidneys, and it can affect the bones and the skin. So, and it can affect the mind because of this repetitive pain, and then the requirement of the patient going to hospital often. So it's a huge problem, and we need to deal with. And how do you deal with sickle cell disease in the best way? Is by enrolling the person into what we call a comprehensive care, okay? And it is best that we identify the disease early or the condition early. So elsewhere, they do newborn screening that is mandatory. In Ghana, we have started newborn screening some decades ago, but it has not been nationwide yet. But recently, we've seen that some other hospitals have taken up after Kolebu, which is a good thing. So assuming that the patient or the person is identified early, then we can enroll that person into what we call sickle cell clinic. And at the sickle cell clinic, there are a lot of things we do. We need to see the person often, and we educate the parents about what sickle cell disease is We educate them on how you get sickle cell disease, what we call genetic counseling. Also, we educate them on how you can prevent the disease, prevent the complications that I spoke about. And some of the complications, for instance, are infection. So to prevent infection, we give the patient penicillin early and up to the age of 5 years. To prevent infections such as malaria, so we give them the normal advices. You have to sleep under insecticide-treated net and all that. To ensure that the person gets a lot of, is up to date with immunization. But we do other normal things as well that we do in hospital, which is checking the person's growth and development. And if eventually the person develops some complication, then we refer the person to the other specialist care, whilst at the same time we control or we coordinate the care that the patient with sickle cell disease receives. So some of the things we do will be the specialist sickle cell nursing, or we send to renal for the kidney problems, or if they are bone problem to the orthopedist, or to general surgery because some patient may need surgery because of the loss of blood that they have often, or pain because patients with sickle cell disease, if they are not well taken care of, they feel pain every day, all right? Or eye care. We do eye care. First of all, you need to prevent. So if the patient has hemoglobin SS, we start checking routinely for eye problem from age 10 years. But if it's SC, we start from age 8 years. And dental care as well, physiotherapy. And we do something else, what we call prevention of stroke, because patients with sickle cell disease can also have stroke. So we check for, we assess the speed at which the blood moves into the vessels of the brain, what we call transcranial Doppler. We start from age 2 years up to age 16 years. So there are many more things that we do at the sickle cell clinic. And that's why it's so important that we ensure the patients and the parents come to the sickle cell clinic often. But also it means that we need to give them the right information and they need to feel welcome. And those things could be some of the challenges why people are not taking hydroxyurea. So elsewhere where they practice comprehensive care for sickle cell disease, you will see that I just want you to focus on the last graph on on the right, on the lower part. So in red, the lower the graph is to the bottom, it means that the worse or the smaller chance of people, children with patients with sickle cell disease, how to live longer. So initially we did not have comprehensive care. And now with comprehensive care, you can see that the graph or the lines are going up, 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 up with time. So much so that now we can almost always bet that 98 or 99% of children who are going to be born with sickle cell disease, if you take good care of them from the beginning, they are going to live a longer life. And that's where we are now. So just not to bore us, we're going to do some poll, and we're going to launch the first poll now. And we will hope, we pray that I'll give you about 1 minute to answer, and then we continue. So what is hydroxyurea? So the poll is going to end in 5 seconds. Good. So from this, we have more than 2/3 of participants who say they have good knowledge about hydroxyurea, and almost all of the participants agree that hydroxyurea reduces the frequency of sickle cell disease. Thank you. So we'll continue from here. Okay. So what is hydroxyurea? Hydroxyurea has been approved by the US FDA for the treatment of sickle cell disease in adults since 1998. But before then, in the 20s, hydroxyurea has been in use for cancer. And it's just accidental that you got to understand that it could help patients with sickle cell disease as well. But the doses that we use for sickle cell disease are much, much lower than that we use in cancer. We've been using hydroxyurea for patients with sickle cell disease off-label, but in 2017, the US FDA has approved hydroxyurea to be used for children aged 2 years and above, which is good news. But in Ghana, it's only recently in 2018 that we got FDA registration for hydroxyurea. So what does hydroxyurea do? In a nutshell, as I shared with you earlier, in sickle cell disease, the beautiful donuts will change shape and they block the vessels and cause many other problems. And the hydroxyurea used over time will tend to change that. So change that abnormal shape and allow the sickle cell or the red cell, to regain or to maintain their normal beautiful donut shapes. All right. For those who have deeper knowledge, I want to share with you that hydroxyurea increases what we call the level of what we call fetal hemoglobin. Is what that hemoglobin that we had in the womb that allow us to keep our mother's oxygen that she gave us for a longer time. And then that's the same thing hydroxyurea does now, so that once you keep more oxygen for longer, you are less likely to change shape. It also reduces the ability of where the blood cells are produced from what we call bone marrow to produce enough of those cells, which is good in sickle cell disease, because in sickle cell disease, it's not only the problem of the red cells, there are other cells, what we call the white cells also, when they are increased in numbers, they can also cause problems. So it reduces the number a little and allows the blood to flow. And then there are many more things hydroxyurea does as well. And there are a lot of studies that have been done all over the world, and also in Africa and in Ghana as well. And that shows that hydroxyurea has many benefits for patients with sickle cell disease. So some of the benefits towards the most common problems that we encounter, first of all, is pain crisis. So the studies have shown that if you give some patients hydroxyurea and you don't give the hydroxyurea to others, those that you don't give hydroxyurea to, they will have about 4 to or about 5 times pain crisis in a year. But if the patient is on hydroxyurea, that amount is going to be half. And then it's also shown that the intensity of that pain is lower, and the duration is also lower, is shorter. How about acute chest syndrome? Acute chest syndrome is this thing that patients with sickle cell disease have. They come with cough, problem with breathing, what we call difficulty in breathing. And they may have fever as well. And then everything looks like they have pneumonia, right? But in actual fact, it's the same thing that I showed you, that the blood being blocked, blood flow being blocked somewhere. It's happening in the lungs. And there are many more other things that can happen as well, in addition to an infection. it can be very severe and it can kill patients. So if you give a patient hydroxyurea and then you watch them over time, you realize that instead of maybe 4 out of 10 patients having that in a year, it's only about less than 2 that will have it, which is very good. And also know that in sickle cell disease, we lose blood. The blood is lost almost on a daily basis, and then they may require blood transfusion, right? But if you give hydroxyurea, the need for blood transfusion goes down as well. How about hospital stay? Because they have to come to hospital to manage the pain, to manage the complications, acute chest syndrome, blood transfusion, infections, and all that. So if you don't give hydroxyurea, studies have shown in average, a patient with sickle cell disease will go to the hospital about 2 to 3 times in a year. But if you give hydroxyurea, it's barely that they will come to the hospital once in a year, which is good. There are other advantages as well. That right here in Ghana, one of the panelists has conducted this study to find out how well do patients with sickle cell disease actually feel if they take hydroxyurea or if they don't take it. So we see that they're okay. Just the fact that you are taking hydroxyurea is not enough. You have to take it properly, what we call adherence. So she compared those who don't take it properly to those who take it well, to also those who somehow take the medicine on a daily basis. And as you realize that the more compliant you are with the medication, or how regular you take the medicine makes you, is associated with how well you feel, what we call the quality of life. So hydroxyurea has many more benefits. Even sometimes we spoke about stroke now, and then studies have shown that in some patients, the hydroxyurea can actually reverse some of the complications that have been already established, either in the brain or even in the heart. So how do we give hydroxyurea? Ideally, in some developed countries or some countries that are rich enough, once a child is diagnosed with sickle cell disease, if it's SS, they are usually started on hydroxyurea. Everyone, hydroxyurea by age 9 months, they started on hydroxyurea. But we also know there are challenges. So because of those challenges, some organizations have come with some guidelines to help us decide who should go on hydroxyurea. Basically, those people that in case you cannot, you want to decide whether they can go on hydroxyurea or not, are those, first of all, that we are afraid that they may get stroke. How do we know that? Is when we check the scan of the brain, that we see that the value, the figures are very high, then the risk of them getting stroke is also high. Then we start hydroxyurea. Or maybe they got stroke already and they also refuse to take transfusion, because once you have stroke, hydroxyurea does not help that much. So we want to prevent a stroke in the first place. And so once you got stroke, normally we give you blood transfusion. But if you refuse the blood transfusion, then we give hydroxyurea. The other reason why we give hydroxyurea is when the patient is having a lot of pain and more often. So what we call by that is when you have a severe pain because of sickle cell disease at least 3 times in a year, it means that you need to be started on hydroxyurea. Patient with severe acute chest syndrome, as we mentioned earlier, or patient with very, very bad anemia that even affecting their life, then we start them on hydroxyurea. There are other reasons why we start patient on hydroxyurea, but we can talk about it during the debate. So before you start hydroxyurea, we just don't jump in, because as we said, and from the study that I showed earlier, realize that it's not enough just to take hydroxyurea. You have to be taking it regularly, right? If you don't take it regularly, the effect that you want will not be seen. And because of that, you need to explain it to the parent very well. Give them enough time to agree, to accept it, to find out, and to come to terms with the other things that will be involved, like cost and all that, and the labs that we're going to be doing. So once they agree, then we can start the hydroxyurea. So we do the counseling by explaining what sickle cell is, what are the types, as I explained earlier, what are the complications, and then now we also discuss their knowledge on hydroxyurea as we saw in the poll earlier, right? How can hydroxyurea prevent or minimize the complications, and what actually is hydroxyurea? And how does hydroxyurea work? So on that juncture, we're going to take our second poll to find out how well we know or how much we know about hydroxyurea. So the poll is on now. So it seems the poll, you couldn't see the poll earlier, so I've relaunched it. So we have 5 questions. So end the poll in 15 seconds. Okay, ending now. And I'm sharing the results. So from the result regarding the first question, hydroxyurea has serious side effects. The audience is split. So less than half agree, almost the same disagree, and the rest don't know. So it's something we need to address in this discussion. Second question, hydroxyurea can cause cancer in sickle cell disease. Most participants disagree, and some don't know. Third question, hydroxyurea can cause skin and nail changes. The majority agree. Few disagree or don't know. Fourth question, hydroxyurea can cause infertility. Most, not most, but people disagree or don't know. Only few people agree to that. And the last one, the benefit of hydroxyurea outweigh the side effects, and the vast majority agree to that. So thank you so much for voting, and we'll continue. So first of all, before we address the side effects, so how soon after you take hydroxyurea and they start working? Usually it takes about 2 months of a regular of compliance before you start noticing the benefit of hydroxyurea. So if you take it for 1 to 2 weeks or so, you may not see anything. How safe is hydroxyurea? Safe. A lot of studies have shown that it's safe. The fewer side effect that you notice will be the nail changes or maybe a mild tanning of the hair, but these are temporary. These are not a permanent side effect. So they take some few weeks and then they will disappear, right? But the other side effects, and those are the reasons why we actually monitor the patient. Often it's the myelosuppression. Yes, we don't want the bone, we want the bone marrow to still work, but we want it to reduce its function a little bit, what you call myelosuppression, but we don't want it to be too much, right? So we check for the blood level, the white cell level. White cells, we still need them to fight infections, so we still check for that. The platelet as well, we need them to clot our blood, so we don't want anything bad to happen. So those are some of the side effects that can occur, but most patients actually tolerate hydroxyurea well. Why? Because the doses that we give are actually smaller as compared to what we will give in cancer. Does hydroxyurea cause cancer? A lot of studies, hydroxyurea being used in the US since the 40s, and by now there's no link between patients developing cancer and hydroxyurea. So how do we take hydroxyurea? That will be the reason for our next poll. So I'm launching the next poll. I don't know if you can see it. The earlier wasn't seen. Maybe I will relaunch.
Yeah, we can see it. We can see it.
All right. So before we talk about the how you take it, I want to discuss accessibility. Okay. So we're going to end the poll now, and I'm sharing the result. So the first question, hydroxyurea is available in my hospital. The majority disagree. Hydroxyurea is available in a community, private, or pharmacies. There's no majority here. People agree, disagree, or don't know the same. Hydroxyurea is free. The majority disagree. Only few people agree or don't know. Hydroxyurea is not expensive. Majority disagree. Hydroxyurea is expensive. Only few agree or don't know. And because of follow-up, we also do lab tests. And we ask the question if the lab tests and hospital visit are expensive. The majority agree that they are expensive. Only few people disagree. So thank you for your poll. So we're going to discuss the availability of hydroxyurea in hospitals or in the community in this webinar, and how the financing of hydroxyurea as well is a huge issue that we need to address. Thank you. So the final poll, I'll just launch the final poll now, then we will not have any poll again. The final poll has refused to be launched. So I'll continue from here. So how to take hydroxyurea? Hydroxyurea is supposed to be taken on daily basis. We calculate certain dose, and then we need to adjust the dose with time. I'm going to show it very soon. And there are blood tests that we do when we are taking hydroxyurea. How much it costs, it will be part of this discussion, but we have to let parents know. And when to stop hydroxyurea, we have to also let parents know. So it depends on what benefit we want to derive from it. And it also depends on how soon after you stop hydroxyurea, it leaves your blood. So usually, once you stop hydroxyurea today, within 3 days, it's as if you've never taken the medicine before. So meaning that if you want the benefits, so you have to take it as long as you need it. But there's issue of fertility that we're going to discuss, and we hope that the audience will ask questions that we can answer. And then what if hydroxyurea does not work? Only in few patients, we see that hydroxyurea does not work at all. So if it doesn't, then we go back to what we know, the old method, which is blood transfusion that we give every month. There are newer medicines that are coming, but they are very, very, very expensive. So maybe those patients would benefit from that. I want to say that even the newer medicine can be used concomitantly with hydroxyurea. I'll try the last poll again. It's still not coming, so we'll leave it. Okay, I'm still sharing this one, that's why. So we'll launch the last poll. So 30 seconds to end the poll. Okay, so the poll has just ended. So to the question, hydroxyurea can be taken, it's actually a statement, it's a question, can be taken every other day. The majority disagree, and also a significant proportion of people actually agree that it can be taken every other day. We're going to address that during this discussion, but I would just want to say that based on what we know about how the drug behaves in the human body, if you take every other day, there's a chance that it's as if we are restarting the medicine daily. It's not going to work really. So we have to find another way to make sure that the person takes the medicine on a daily basis. It's only in some extreme cases that maybe there are some drug-free days, maybe on a Sunday and things like that, because it's difficult to prepare a suspension because it comes as a capsule. But now we have some dispersible form of the medicine in tablet that you can just dissolve. And based on, because of these new forms that are available, we have no reason why we should still be giving free days to some patients. So if we want to have the benefits, it's better that we give the medicine daily. Is it preferable to take hydroxyurea at the same time of the day? So almost everyone has agreed, of course. So again, we want the amount of the drug to be almost the same in the blood. So if you take it at the same time, almost at the same time, so we'll still have the same level all the time. Thank you so much for responding to the poll. I've stopped now. Okay. So before you start hydroxyurea, there are certain labs that we do to make sure that the person bone marrow is not working, is not already suffering, right? So we do what we call the full blood count. If ideally we want to do reticulocyte count as well, again, to make sure that the bone marrow actually is active and there's no other problem. And then we check the kidneys, the liver, because that's those other areas that the drugs is going to pass through. So we need to make sure that those organs are fine. We do some viral tests, again, because if hydroxyurea in some patients is going to weaken the person, we don't want them to be having some infection lingering on that are going to become worse. If it's possible, we check for this hemoglobin that I spoke about that we call hemoglobin F. We check the level, but it's not mandatory. And we also do the transcranial Doppler for children between 2 years to 16 years, as I mentioned earlier, to find out where they are already, if they are at a higher risk of stroke or not. And then if the patient on after you get the result, then you want to start hydroxyurea. So usually start at the lowest dose, okay? So that's not the optimal dose. The optimal dose is the highest dose you can give and the patient is still tolerating and it's giving you good result. And the highest, it could be like a value of 35 or what the person can tolerate below that 35 without any problem, right? So we begin usually around 18 to 20 milligram per kilogram per day. If you are getting a capsule, then you want to calculate the dose and round it up to the nearest 100, right? Ideally, you should observe or you should mandate somebody, a caregiver, to actually observe that the person is actually taking the pill on a daily basis. But for children, you want to observe them taking the pill in the clinic if they are old enough to see if you actually can tolerate it. We have seen some older children, even older than 8 years, that cannot swallow the pill. Then in those patients, we need to actually prepare suspension And then now that we have tablet available, then why not? They can be on tablet. The problem is that the tablets are more expensive than the pill. And again, we hope that we get some solutions from this discussion today. But if you are prescribing tablets, the tablet can come as 100 milligram or 1,000 milligram form. There's no need for preparation. You just give them one prescription and then make sure that they take the medicine on a daily basis. And you can round it around the nearest 50 because the 100 milligram can be divided, even the nearest 25, because each tablet can be divided into 4. So any dose modification, what we do is that when we put a patient on medication on the hydroxyurea, we review them every 2 to 3 months, depending on the indication, and then we change the dose. Why? Because we want the highest dose possible that can give the effect, with the maximum being 35, right? But we want to make sure that the body is still tolerating. And sometimes too, once we are on hydroxyurea, you expect that the person will grow and they will gain weight. So because of that weight gain too, the actual dose will become lower because it's a weight-based dosing. So we have to take that also into consideration. But at any given time, we don't want to change the dose more than 5 milligram per kilogram per day from the previous dose that we were given. And then once the person is on hydroxyurea, we need to follow up, okay? So initially, we want to follow up with a full blood count at 2 weeks, then monthly thereafter. And some patients, we can even space it more, especially those who live far away. We can find another way to monitor them. They can send a result through WhatsApp and all that. And then we see them only on the day of clinic, which is within 2 months to 3 months. And each time you have that they bring a result, either through WhatsApp or they show it at the OPD, make sure that you find out if they have any issue. Just the parent, you can just ask the parent and then monitor the result to make sure that the hemoglobin is going up. The size of the red cell is going up, what we call MCV. It's one of the ways to know that the patient is actually taking the medication. And we want the WBC, the white cell count, to go down, but you don't want it to be usually below 1, okay? Because in sickle cell disease, white cell count are usually very high, and you think they have infection, but they don't have infection. It's just because of the inflammation they have every day. And if the white cell counts come down, then you'll see that they will feel much better. They will have less pain, okay? But if the counts are very low, so the neutrophil count is less than 1 or platelet is less than 80, you want to discuss with a hematologist. You may want to stop the medication for a while and check. Okay, but it's always good to discuss before because there are other reasons why you can see those results. And then they come for routine. Whatever we do at routine clinic, like a comprehensive clinic, we'll continue that. They have to continue their routine medication, including a penicillin V for children less than 5 years. They have to continue the folic acid and a zinc-containing multivitamins. We need to make sure that in children, we monitor their growth. They are still continuing their immunization. If they are in adolescent, check their puberty, check their performances in school, or find out if they have any other psychosocial issues so that we can address those issues quite early. And for the adolescent girls, we need to have a special clinic for them where we discuss sexuality and contraception and all that, because potentially hydroxyurea can cause problems in our unborn child. So we want to make sure that we prevent that. And always find out if they're actually taking the medication, okay? And as I said earlier, one way to find out somebody is taking the medicine really is that the red cell size is going to go high. What we call the mean corpuscular volume, or MCV, is going to go high. And the hemoglobin level, the blood level, actually will go high if they're actually taking the medicine and if the medicine is working for them. If they come with side effects, as we mentioned earlier, like the darkening of the nails, or maybe the thinning of the hair and all that, we need to reassure them that those side effects are not long-lived, they are transient. So they are going to disappear, okay, and then encourage them to take the medicine. So the reasons why we'll stop the medicine again is when it's causing major problem, as we are saying, a severe myelosuppression. So this is how often we do the labs. So the full blood count, we do it before starting and then every month, or we can space it depending on the circumstances. We check the kidney function and the liver function and the serology before starting and every year. We check the urine also to make sure that the kidneys still are functioning properly. We check the speed at which the blood moves in the brain, what we call a TCD, ideally before, if the child is between 2 to 16 years, and then we do it every year. But if anytime that we get an abnormal result, we want to repeat the TCD within 4 to 6 months and take action. If the child is aged if the child is aged 10 years for HBSS or 8 years for HBSC, we want to send to the ophthalmologist to check the back of the eye to make sure that they are not developing a visual problem because of sickle cell disease. There are other tests that can be done as well, but they're always good to discuss with the hematologist. So now, if hydroxyurea is working like marvelously, why are we still having problems? Why are people not taking it? So one of the reasons that many doctors actually don't have a good knowledge on hydroxyurea. And there are studies that have been done in Nigeria that to prove that point, that the reasons why doctors were not prescribing hydroxyurea is because most of them felt like they lacked the expertise, or maybe nobody actually put guidelines together for them to know how to give the medicine. And some people actually are afraid of the side effects. We've seen in this poll that a significant number believe that there are significant side effects with hydroxyurea. So because of that, so another studies have wanted to find out, okay, what can we do to improve the way doctors prescribe medication? So the reverse of what we saw earlier is true. So in green are the people who actually prescribe hydroxyurea often and the reason why they do so. And then in red will be the reasons why, or the barriers of they not prescribing. Again, here you can see that those who prescribe felt that they have good knowledge of hydroxyurea, and then they know what the hydroxyurea does. And even though they acknowledge that it is costly, they realize the benefit they derive from it are much more than the risk. So that same study also asked nurses, and the conclusion is that because those nurses are the one actually who counsel the patient and who follow them up, and we know that nurses develop this personal relationship with patients. So we wanted to find out what motivates them to talk to them about hydroxyurea and ensuring that they take it daily, or otherwise, why are they not doing so? And then the results show that most nurses will actually advise patients and the caregiver to be on hydroxyurea if they feel like it's helpful. And again, if they can see the results of hydroxyurea. So those who actually do so, because they have seen the effect of hydroxyurea, they have seen that patients have less crisis. Even though hydroxyurea wasn't free, they acknowledge they've seen the result. That's the reason why they advise or they counsel patient and the caregiver to be on hydroxyurea. And the nurses who don't, only few felt that they have inadequate knowledge, but the majority said that hydroxyurea was very expensive, but also adds to their workload because, as I said, as we saw earlier, if you're on hydroxyurea, we need to monitor the patient just to make sure that we don't have any side effects. Even though we know for the studies that have been done that it's safe at the doses we give, we still don't want to become complacent. So, but some nurses felt that doing so increase their workload. That's the reason why they won't they will not want patient to be on hydroxyurea. How about the patient, the caregiver themselves? Those who take hydroxyurea regularly, only like a 50%, half of them felt that they have good knowledge of hydroxyurea, but the majority or the vast majority experienced the reduction of frequency because of hydroxyurea, and that's the reason why they take it. And again, they acknowledge that hydroxyurea wasn't cheap. Okay. And those patients who will not be on hydroxyurea, almost all of them felt that they had no knowledge, meaning that we need to educate them again. And hydroxyurea is very expensive, and then they don't find it always to buy. And the lab tests that they have to do in addition are also very expensive. And also they are afraid, some are afraid about cancer, even though we say that a lot of studies have shown that hydroxyurea is not associated with cancer with the doses that we give. And interesting enough, some people are afraid of the skin and nail changes, and that's the reason why they are not on hydroxyurea. So, addressing the problem of availability, how available hydroxyurea is in our hospitals and communities? The polls have shown that it's not available most of the time. And there's a study in Cameroon and DR Congo that also confirmed that if you take 10 pharmacies, you will see only hydroxyurea in 2. And then mostly those pharmacies where you see hydroxyurea will be in bigger cities, and it's very, very expensive. So if hydroxyurea is expensive, it's not available, what's preventing us from actually importing it so that most pharmacies will have it? Can't we just produce it ourselves? So these questions have been posed to some pharmacists in Tanzania, and they will not really go into it. Why? Because most of them felt that they did not have enough information about the effect of hydroxyurea in sickle cell disease, and others felt that it's not really, it doesn't make any economic sense because they thought the patients are few, and they importing the medication for those few patients does not make sense. But actually, if you see the population of Ghana, we have 2% of children who are born each year who will be born with sickle cell disease. So it is important. So we have a huge population of patients with sickle cell disease who are out there and mostly undiagnosed because we don't have universal newborn screening. So there's a market there if pharmacists are thinking that way. So let's come down to hydroxyurea in Ghana. So recently, a study published in Kolebu, which is the biggest hospital in Ghana, that has the highest number of patients being followed up for sickle cell disease. They found that most patients who need hydroxyurea don't get it. So as I said earlier, normally, if you are diagnosed with hemoglobin SS, you should be put on hydroxyurea. But because of challenges, then we will come with criteria to make sure that, okay, at least if you don't get it automatically, if you have these things, you should be started on hydroxyurea. So based on those criteria, in Kolebu, they found that only 1 out of 10 people with hemoglobin SC who actually meet those criteria. No, let me take it the other way around. They found that if you apply those criteria, you'll find at least 1 out of 10 patients with hemoglobin SC, and about 3 out of 10 patients with hemoglobin SS who meet those criteria. Then if you see actually those who are on hydroxyurea, that's amazing. It's only 1 out of 100 of those who are SC, and then 3 out of 100 of those who are SS who are on hydroxyurea, meaning that those 97%, almost all the patients who need hydroxyurea actually are not getting it. And then we also tried to ask some of our patients just prior to this webinar about their own perspective. And what we found was that, first of all, the sickle cell disease is diagnosed late in their children or in themselves. And even though it's diagnosed late, they even take longer time to be enrolled into clinic where they're supposed to be followed up, counseled, and make sure that you prevent or treat complications in a timely manner. And those who actually go, they felt like they are not well educated about sickle cell disease. Again, if they are not well educated, there's no way they'll be put on hydroxyurea. Eventually, those who are put on hydroxyurea felt that it's beneficial to them or to their children. Now, the children who used not to eat now are eating enough and playing, and they are not getting sick, often not getting crisis. We found out just as the polls suggested, how accessible the medicine was. Almost all of them come back with the financing, the prices that are very high for hydroxyurea, which make them, some patients, difficult to take hydroxyurea on a daily basis. Sometimes they have to stop for a while and come back again. You can see that if the medicine is expensive, you take it and you stop for a while and you come back again, it's just like waste of money. So almost all of them advised or pleaded that NHS covers the medicine. So in actual fact, a lot of things have been done in Ghana regarding accessibility of hydroxyurea to patients with sickle cell disease. From 2018, there's the Ghana Novartis Hydroxyurea Sickle Cell Program, through which free hydroxyurea have been provided to almost 4,000 patients with sickle cell disease all over the country. And 2 years ago, at the 2021 World Sickle Cell Day, the government has announced that hydroxyurea will be covered by NHIS. In actual fact, some pharmacies actually will prescribe or will provide hydroxyurea on NHIS. But again, the poll suggested that it's still not available, and we want to have a discussion on it and decide what the solutions will be. So before we start the discussion, I want to conclude by saying that if you compare the newer medicines or other ways of treating sickle cell disease, you will see that hydroxyurea is the most affordable, right? But we still have problems with it in terms of knowledge, in terms of cost, in terms of availability, and then the fears of the side effects. So again, these are not to be taken lightly. We want to discuss it and come up with solutions. So thank you so much. So I believe that the floor will be open now. Mary.
Okay. Please, can you, my video?
Yeah, I made you the host, so you can control it from here.
Okay. So, Koku, this shows that you've really been around sickle cell for a very long time. So thank you so much for this comprehensive and insightful presentation. Thank you so much. I will urge everybody to put their, I think the chat is not enabled for everybody. I don't know how.
You have
But then
questions?
you can put it in the Q&A. If you have questions, put it in the Q&A. We'll have time to address that. But then, as I said, we have Dinah. Dinah has been in this sickle cell space for like 12 years. I've known Dinah for more than 12 years at Kolebu. I work with her. I was in the adult clinic and she was in the children's clinic, sickle cell, but I used to go and help out during clinic days. So Dinah, I want to know your take. Can you put your camera on? The panelists, can you put your cameras on so that your audience can feel you? Can you put your cameras on?
Mary, you have to allow us now that you are the host.
Okay.
You can put our cameras on directly. You can switch it on or allow us to put it on.
Let's see the camera. Koku, I think you are now the host.
Yeah.
So can you put the cameras on, and then you make me?
Yes, but we can start a discussion as I do.
Okay, so Dinah, as you've been in the sickle cell space for some time, I want you to at least, is there anything you want to add to, since you are also a health professional, you are a nurse, is there anything you want to add to Koku's presentation in terms of the counseling and the HU, hydroxyurea guidelines? How has it been successful? Has it been successful? And what has been some of your challenges in terms of the counseling and the hydroxyurea guidelines? Can you share a bit before we move on to other panelists? Thank you.
All right, thank you, Mary, and thank you everyone for having me. Koku has done a yeoman's job to the topic. So I'm just going to add two things. The first one I am going to talk about is to our clinicians and to our nurses who have joined us, and to even the patients who have also joined us who are on hydroxyurea. One of the big challenges that we have is the fact that when the patients are unwell and they get admitted or for an infection or for pain or something, we tend to stop the hydroxyurea. So this is what I'm appealing to the parents, to the clinicians here, to the nurses here. When a patient actually has an acute episode, that is the best time they need to be on the hydroxyurea. Hydroxyurea has a half-life of just 8 to 12 hours. So if you admit the child for pain for 4 days, and this child stays off the hydroxyurea for 4 days, and Koku has just said it, the child goes back and starts the hydroxyurea, starting from almost afresh. And so please, if the patient comes to you, whether the patient has malaria, has an infection, has pain, please ensure that they continue the hydroxyurea. Even if they come on admission, they may have left the hydroxyurea at home, not knowing they will be admitted. Please encourage them, get them to bring the hydroxyurea in. And then if you are the clinician attending to the child, please make sure that you add the hydroxyurea to the patient's medications. Otherwise, the nurses also assume that, oh, this is not on the treatment sheet, so we can't serve it. So sometimes the mother wants to serve it because she's been told that the child needs to take the medication every day. And this is the case, the nurse says that this is not on the treatment sheet. So we all have a responsibility to play in. You, the clinician, make sure that the patient's hydroxyurea, as part of taking your history, the patient is on hydroxyurea, ensure that you've added it to the patient treatment sheet. And if you're a nurse and the patient shows the hydroxyurea to you, that this is medication I'm supposed to take every day, please, if you check the chart and it's not on it, show it to your clinician, let them get it on the treatment sheet. And if the patient has left it at home, ensure that they bring it in. If for any reason you want to stop the hydroxyurea because of toxicities, please speak to the doctor that is attending to the patient. Because sometimes it becomes a banter between the patient and then the doctor. I said, stop it. My doctor says I should take this medicine every day without fail. So if you are in doubt, unless you have toxicities where the hemoglobin levels are low or the patient has a cytopenia, then you want to stop it. But apart from that, please, we are just a stone or phone call away. Just liaise with us before you stop it. So that is one important thing that I want to add. The second one is about the counseling. The counseling in starting hydroxyurea is very, very important. If you get the counseling wrong, you are going to have so many issues. Because don't forget that if you are giving the information to the patient stays in the community. The patient can read on the net. So you need to give the information and explore every single aspect of it. Allow them to ask questions, answer the questions factually. Because if you hide anything from them, and normally the first thing you need to let them know that this is a cancer medication, because when they go back home and they Google, that's the first statement that will come. And then based on that, you can allay all their concerns about it. If you don't do this and they go home, the home doctors and the nurses will fill in your gaps for you. And I've had patients that have been prescribed hydroxyurea at certain facilities or even in Kolebu. And after 2 weeks, the patient returns with a lab and you say, okay, how is the taking of the hydroxyurea going? and the patient tells you that, when I go home, my husband checked on the net and says that this medication is a very dangerous medication, so we didn't start. That means that the counseling did not go well. So it is not always that you can have the parent or the caregiver decide on the first day that you do the counseling. Sometimes you may need to get insignificant others to also come and sit in, because this boils down to adherence. The medicine only works if they are taking it. So if you are speaking to the mom and the father is the breadwinner or the sole financier, it's important that you make time and get the father in. Sometimes the child may not be staying with that particular parent, may be staying with the caregiver. So when you are doing the counseling, you need to get the caregiver in so that they will also understand what it entails in the medication. So the counseling is very, very important. You need time, you need patience. You, the person doing the counseling, you should understand and have your facts before you talk to the patient. If you don't know, nothing changes you from saying that, can I go back and check? And then answer their questions factually. Give them reading links to go and read. Sometimes, even before we start, we give them reading links where we put down any concerns that you have about it and come back and let us address. And I can bet you that the patients that understand and have gone through proper counseling, they make your work easier. They're able to read their labs, they know the importance of the medication, and they help you go through the journey. But if they have gaps in the counseling, I bet you will have issues. So whoever is doing the counseling is very, very important. Give them the facts, tell them about where they can find the medication, tell them how you're going to support them, where it's accessible, and all the support that is available for them. So that's my contribution to the discussion.
Okay, so Dinah, thank you so much for that brilliant insight. You've also been around sickle cell for a very long, long time. Now, I will. Can we speak to Elisa? Can we speak to Elisa, your daughter? Okay. Can we see Elisa?
Can you hear me?
Yes.
Okay, so I don't know if our...
I want you to, we want to see you. We want to see her.
We still don't have, so we don't have the option for video at the moment.
No, I did.
From our end.
From your end. Okay, that's fine. That's fine. So can we speak to her? Elisa,
absolutely.
Elisa, can you tell us how old you are and how long you've been using hydroxyurea?
I'm 15 years old, going on 16, and I've been using
There's a break. Okay. Can you hear us? Okay. All right. So can we move on? When they come back, we can get back to them. I want to know.
Harry, there are a lot of questions in the chat box.
Yeah, we'll do that. We'll do that after the interaction. We'll do that. Let me go to Dr. Ebenezer Biafi. You are the provider. You are the pharmacist. You are the pharmacist at the whole teaching hospital. In terms, I wanted to ask Elisa some of the benefits of using hydroxyurea. Okay, so I want to ask you. Is there any benefit? You've been prescribing it. Is there any benefits when it comes to? I mean, Koku spoke to that, but with your lived experience, is there any benefits? Like something small for us to know.
Thank you very much. So as my boss indicated earlier, yeah, there is benefit. The drug actually works on three aspects of the disease progression, or how the crisis, or how the pain and all the complications that come with the drug will ensure that you have more of the fetal hemoglobin, which he mentioned. It also helps to control the vaso-occlusive crisis, which is the main reason why you get these patients going to the hospital and getting admitted. And the stroke as well, because it also helps to maintain the integrity of the blood vessels. So yeah, in whole, the drug has really been out and patients are benefited. Thank you.
Okay, thank you. Again, Dr. Biafe, I want to get to you again. As I said, you are the provider.
Yes,
If somebody takes hydroxyurea, okay, how long does it take for the person for it to work? You know, Koku talked about how they should be taking it, okay, and I think Dinah made mention of something like that. So how long, if I'm on hydroxyurea, how long would it take for it to work in my system?
Okay, so people respond to drugs differently. You know, a patient could start hydroxyurea and may benefit within the first 2 months, like Boss initially said. But then how fast the drug would work would depend on how you take it, because it's a drug which is water soluble. It means that it will dissolve in water completely. So you are advised to drink a lot of water, so that once you take it, you drink a lot of water, everything dissolves and you get a good amount of the drug in your blood. So if you do it right, then we are expecting that within 2 months, you should get response. And in fact, there have been several studies where patients who were not on hydroxyurea, had their pain episodes within 1.5 months. But those who were on it first time, lived for, stayed for 3 months before they got their first pain episode. Yeah.
So the same question, but turn around. So when you stop hydroxyurea, how long does it take for it to stop working in your system when you stop it?
Okay, so that actually helps with discussing medication concordance, a discussion between you and the patient, so that you are on the same page on how you are going to take the drug and all that. Once again, how long the drug's effects will go away in layman's term also depends on how much you had in you and how you were taking it, and then what we also refer to as the half-life. So many studies will be telling you that the half-life of the medicine is about 4 hours, meaning that if you took the drug, the next 4 hours, half of what you had in your blood would leave. There again, the drug has a good equilibrium, a balance between your body, the tissue, and then plasma, the blood. And then the kidney is what is clearing the blood, the drug. So about 40% of the drug that you took in would leave in your urine. Okay, so if you stop taking the medicine and the half-life of the medicine is about 4 hours, then you are expecting that in a matter of 2-3 days, you are going to clear everything from your blood. There again, the clinical effect will be determined based on other factors, because the clinical effect is different from what you had in your blood that had been cleared. And same way as people respond differently to the drug is because of how our body is made. Then we are expecting that in about 2 months, clinical effect is going to go off. If you are not taking it at all, then we are going to get that your usual painful crisis. Yeah. So adherence is very necessary. Thank you.
All right, thank you. I think Elisa is back.
Oh.
So Elisa, can you tell us, I think you didn't tell us when you started using hydroxyurea, you went off then. Are you here? Because I can see you. Why are you here? Okay. So, what can you, can I
Yes.
speak to? Okay. So, Elisa, when did you start using hydroxyurea?
About 4 years ago.
Okay, that's nice. So, have you seen any benefits?
Yes, I
How,
find
how,
oh,
go
I
ahead.
find hydroxyurea has made my immune system better, and I don't get sick as often. I don't experience as many crises as I did before.
Okay, what about your mood?
In regards to my mood, I don't think much has changed. I just find that I don't get sick as often.
Okay, what about your energy level?
I'm able, well, it has in a way improved my energy levels since I'm able to do more things that I used to not be able to do because I would experience it.
Okay, that's great. Now, you've been a caregiver for some time now. Elisa has been on hydroxyurea for 4 years. Can you say anything about the benefits?
Well, I think the benefits are endless because I double as an advocate. So I get to see it from from the bigger picture perspective. And one of the major benefits is the significant decrease in the number of crises she or anybody I've seen take the medication, tends to experience. So we've gone from maybe multiple visits within a year to one or maybe not at all. And sometimes even if we have to go to the hospital, then it's for a different reason, unrelated. And also, the ability to engage in activities that before we would either be fearful of engaging in, for instance, swimming and, certain sporting or physical activities because of the fear of going into a crisis right after, engaging in those activities. So we've seen, a benefit in that regard. And, just the peace of mind you get from not having to worry about potential crisis because of the illness is great. And then finally, the ability to travel, that flexibility where you don't have to worry about, oh, what do I need to look out for if I'm traveling, whether it's within the country or even outside the country, certain parts where you might not be able to get access to certain services. So before, if we had to travel, you would have to think about all of those things. But now not so much because that hydroxyurea, it's working well and we are able to maintain without the potential, risk of going into any form of crisis or infection. So those I would say are sort of the major benefits. And, and overall is the reduction in cost of, accessing healthcare and treatment because you're not going into the hospital as often, you're not getting admitted as often, you're not getting blood transfusions as often, you're not taking or taking expensive antibiotics as often, and just better quality of life.
So thank you so much. I will for that insight because you are speaking as a as a caregiver here. I want you to speak as a caregiver here. When it gets to the advocacy, I will let you know. Anyway, so let's move to the next question. I want Elisa to speak to this if she can. Elisa, is there any challenges with hydroxy use? Do you have any challenges with your hydroxy?
At first, it was definitely a challenge to get used to taking it every day. And you'll have to go for constant checkups to make sure that it's performing its function, But now I find that I don't have many challenges with taking hydroxyurea.
Okay, great. I want you to speak before I move to to the rest of the panelists. So do you have any challenges with her or in general with hydroxy use?
Well, as a caregiver, I think that, right now, the issue that we are facing with hydroxyurea is accessibility. While I can afford to, buy the medication for my daughter, I know that a lot of people have a challenge with that. And, even though we were able to advocate for the medication to go onto the NHIS system, it's still not that accessible and available to, to us in a lot of centers. And unfortunately for us too, the recent challenges have also, deepened that challenge in the sense that, it's difficult to bring the medication into the country. It's costs more. The dollar rate impacts the cost of it, and so everybody tends to feel that effect because it's a nationwide problem. But definitely access and cost of the medication.
Okay, great. Since you've mentioned cost, I want to go straight to Dr. Ebenezer Wiafi. How available is hydroxyurea? I mean, you at Hull Teaching Hospital, but can you speak to that? How available is it? Is it available in the pharmacies? Is it available in the community pharmacies? Is it available in the hospital pharmacies? Like how available in general, not just the Hull, but then in general?
Unfortunately, we do not have at the hospital, but we have. When Ojo was running for the 2 years, it was okay. Intermittently, you may have some shortages, which is normal, but then we've been trying our best. I know when they put hydroxyurea on the NHIS list, the list had to be updated, right? So last year, they put it on their list, 2022. But the medicines list was updated in June 2022. So in June 2022, the cost of the 500 mg capsule was 2.3. So for each 500 expense, NHIS is going to reimburse Ghana cedis. Okay. Then again, we move to 2023. That's this year. And then they updated the list again in February, and they increased it to 2.76. Okay. But in general, if you look at the pharmacies, you are likely to buy the 500 mg capsule around 3.7 cedis, 4 cedis, even 5 cedis. Mm-hmm. So there's a major gap in terms of how much is on the NHIS list and then how much you are going to pay, in the community pharmacy. There again, let's not forget that in the design or in the development of these billing schedules, the NHIS does not factor payment of the professionals or the facility or rental, electric bills and all those things, because the hospitals are government institutions. So the hospital being a government institution, NHIS will only be looking at the medicine. Why? Because government pays me. I'm the pharmacist. NHIS does not pay me. It's government who pays me. But then you go to the pharmacy, the community pharmacy, they pay themselves. So you are expected to buy it higher over there. But then what we can do with the pricing is that, to be honest, NHIS has really helped. They've been very helpful. But you put the medicine on the list and you update it in June, okay, June 2022. But then the procurement process has already ended. The awards for drugs to be supplied have already ended. So how do you get the medicine? That's the whole thing. It's on the list, all right, but it came late. And so management will have to rely on what we call emergency purchase. And emergency purchase has got a cap. That is 5,000 cedis cap. That's emergency purchase. So if you put it on the list in June, and then by June, they've ended everything and they want to rely on an emergency purchase, how much can they buy? Let's not forget that each capsule on the NHIS list last year was 2.3. This year is 2.76.
Okay, so Dr. Riafe, so let's talk about the solutions now. So what do you think can be done with regards to availability? Because I'm in Hohoi, the Volta Regional Hospital. Patients there they buy. I mean, if you look at the results that the research that Koku presented, they buy, and also the pharmacies is only just one pharmacy that has hydroxyurea. So what are some of the solutions to this? Because it looks as if hydroxyurea is only in the main teaching hospitals. Okay.
Yeah. So another thing with the NHIS is they have drug classification. The mere fact that we hear or we heard that particular medicine was or is on the list does not mean anywhere you go, you get it. If you check the list, hydroxyurea is classified as a specialist medicine. SM is written there bold. So if you decide to keep it in a district hospital where there are no specialists, then patients will have to buy. So that's one key thing. Unless there's a visiting specialist, and then you make NHIS aware that we have this visiting specialist and that this is the clinic day. So we know that all prescriptions for hydroxyurea that will be given in that district hospital will be done by this specialist, and so they will reimburse. One thing that we may have to revisit was the technique the Ahoju program was using. There was an app that they were using to track and all that. A similar thing is being done for trastuzumab for breast cancer, which I ran over here. So for that too, it's well controlled and it comes directly from Roche. So the medicine does not go to a third party for prices to change. And since last year, about 2 years ago that they started, it's even been over 2 years. The price of the medicine has been stable. Not even a peso has been added. So if Novartis could look at working on this accessibility, on a large scale, because the patients are there, then they could also look at revisiting the Ahojo model, maybe borrowing, some techniques from the Roche system that they are using to run trastuzumab, because it's very expensive. Trastuzumab is almost 4,000 cedis per shot, and each patient takes it every 3 weeks for a year. And NHS is paying. So it's working, but we have to find a way, to ensure it works. If the drug is going to go through a third party before it gets to the hospital, prices will go up. So we have to discuss the accessibility, issue very well, probably on a large scale, involving Novartis.
Okay. All right, thank you. I want to take some of the questions in the chat. This one says, in the comprehensive care for sickle cell disease patient, nutrition or proper diet is left out. Is that to say that nutrition is not important to SCD patients? Koku and Dinah, do you want to take this?
No, that's a very good question. I think I mentioned it. It's just for the sake of time. I spoke about growth and development. So we take care of nutrition very well during the sickle cell clinic. So we assess patients automatically or systematically each time we see them. And if there's a problem, we refer them for nutritional assessment. But most pediatricians and other people who take care of patients with sickle cell disease also have a good knowledge of nutritional issues. It is when you have the serious ones that we require specialist attention. So we haven't left it out. Probably just a question of time. So it's part of the slide actually.
All right. So the next question, it said, are there alternative medicine for hydroxy for hydroxyurea, considering the long-term effect. But did we say long-term effect? Did we say there are long-term effects?
So first of all, we need to understand. I mean, it's still, I mean, the fear, and then people are right to be afraid. But that's why we're having this discussion. Actually, you don't need to be afraid. Okay. So the long-term effect you can feel or you may be afraid of is what we call people usually mention infertility. But if you take sickle cell disease alone, this sickle cell disease is a huge risk factor for infertility. Okay. But it is shown that if you take hydroxyurea, if you are a man, for instance, your sperm count may be low. Again, it is shown that if you stop hydroxyurea, the sperm count goes back to where it was before. Okay, but it's in the women that, okay, if you take hydroxyurea whilst you are pregnant, your unborn child may have issues because of the nature of the medicine. But in actual fact, some of our patients who accidentally got pregnant was on the medication, because usually we advise them to stop the medication if they want to become pregnant. So accidentally, some became pregnant whilst on the medication, but we haven't seen the effect that we thought we would see in their babies. Doesn't mean that we are advising anybody to take hydroxyurea during pregnancy. But if you are afraid of long-term side effects, those are the things you can think about. So in actual fact, we don't have those long-term side effects that we're actually talking about. But are there alternatives? Yes, there are a lot of alternatives. As I mentioned, the blood transfusion every month. But if you compare blood transfusion to hydroxyurea, you see that blood transfusion is more expensive. All right. But there are newer medications now. You hear some difficult names to pronounce, like crizanlizumab, vexillotor, and things like that. So they are very useful, but they are very, very expensive. So if hydroxyurea is throttled, you imagine that those medications will be like some, what do you call it? McLaren and all those expensive cars. Okay, they are very expensive. But now there are other ways. I mean, you hear in the news recently, they talk about gene therapy to cure the sickle cell disease. Again, they are very, very expensive. It's not something that we advise patients straightforward, because to get to those therapies, you have to count millions of dollars for now. So that's where we are. So for now, if you compare hydroxyurea, first of all, we don't have the long-term problems as people are thinking, and it's very affordable. Only a few patients may not benefit from it, but the vast majority will benefit from it. And it's well tolerated.
Okay, so I think I want Dinah to take this one. We know that hydroxyurea increases the HB count. So somebody is asking, can it also reduce it?
All right, so that's why it's important that when you are on hydroxyurea, you do the labs that, the monitoring labs, because we look out for some side effects, apart from what Dr. Mega talked about, that the white cells need to come down, the platelets need to come down, so the blood is lighter to move. Now, as you are taking it, we want the hemoglobin level to go up, because if you are making more of the fetal hemoglobin, then your cells don't break down. But if for any reason you are taking the hydroxyurea and your hemoglobin level is dropping, then that's what we call toxicity. So sometimes we have a level that we start from. But if we realize that you are developing toxicities, we may withhold the medication for a while, restart it at a lower dose, or we investigate that, are there other things that is making your hemoglobin level go down? So let me give you an example. Patients with sickle cell can have very big spleens, okay? So if you have a big spleen, the spleen can actually pull blood in there periodically. So if you have a big spleen and that is there and it is causing that problem, that could also cause your blood level to come down. So if we don't deal with that spleen problem, then as you're on the hydroxyurea, yes, you're on the hydroxyurea, but then the spleen will be causing counterproductive things. So if the HB is coming down, it's important that the clinician will look at it and determine why the hemoglobin level is coming down. Is the patient taking the hydroxyurea? So this is somebody that when you started, were you compliant? Was the hemoglobin level going up and suddenly it is coming down? If it's coming down, you need to ask 2 questions. Is the patient compliant with the medication? That is number 1. Number 2, is the dose that the patient on optimal, what we call optimal dose, is it enough for the age? For the age and then, sorry, for the weight. Those are very important. Then 3, you look at your labs and see that are there other things that could be happening? So the person that put up the question, whether you're a clinician, then please look at these aspects of your patient. If you're a patient, this is a conversation that you need to have with your doctor, to look back at your labs to see when you started, what was going on, what has been happening of late that is causing your hemoglobin levels to come down.
Okay, thank you, Dinah. Koku, somebody is, or should I give it to Dr. Riafe? So what's the difference between pills and tablets? I mean, when it comes to hydroxyurea, the person wants to know what's the difference between pills and the tablet. Because I think Koku kept talking about pills and tablets when he was doing his presentation. Or Koku, you want to take it?
Well, I actually spoke about capsule.
Okay.
I spoke about capsule and tablet. So the form of hydroxyurea that we had was in a capsule form, 500 milligrams. I'm saying that now we have tablets that are dispersible. Some are 100 milligrams, some are 1,000 milligrams. But now when it comes to pills, I think it's a generic way of a name people give to medicines they take all the time. I don't know how well, I mean, some people can use pill for tablet or for capsule, but
okay.
In this case, I'm mentioning capsule and tablet.
Okay. Okay. So somebody is saying, how should HU be used in pregnancy?
So I think
Okay,
I've answered that question.
Okay.
Yeah, Dinah can take that.
Okay.
So I think we are trying to also respond to some of the questions, but then this is very important. So one of the precautions that we take if you are on hydroxyurea is that you have to have a planned pregnancy. If you are taking hydroxyurea, you cannot get pregnant by mistake. Reasons that Dr. Amega has explained earlier. So before we put you on hydroxyurea, if you are somebody who have attained menarche, that means that you started having your period. One of the labs that we do before we put you on is to do a pregnancy test to make sure that you are not pregnant. Now, as the patient goes on, for us, we start as early as 9 months. So our children grow up to attain menarche still with us. So every time that they come to clinic, you need to find out, has your period started? As soon as the period starts, you need to have that important conversation. That you see this medication that you are taking, you cannot be pregnant whilst you are on these medications. So you need, if you have to have sex, and this is a conversation that in our part of the world, we feel very hesitant, but this is very important, especially if your patient is on hydroxyurea. If you have an adolescent that is sexually active, you cannot put under the shelf that the parent is there, so they can't do anything. You need to let them know that if for any reason you are going to have sex, you need to have what? Protected sex. And this goes for both males and females. So if you're a male and you are taking hydroxyurea, you cannot go and have unprotected sex, because if you have a child with somebody else, then we are having the same issues. So again, if you are a female or a male and you want to get your wife pregnant, or you, the female, you want to get pregnant, you need to have a discussion with your clinician. The hydroxyurea will be stopped. And once it is stopped, after 10 days, everything is gone. And then you can get pregnant. Once you get pregnant, now we have the comprehensive care for pregnant women in Kolebu. So once we take you off the hydroxyurea, you're enrolled and you get pregnant, you're enrolled into that comprehensive care, which is run by the hematologists, the obstetricians, okay? And then there are some nurses attached to it. And you'll be followed up throughout your pregnancy after breastfeeding, and then you'll be put on. So the precaution is that once you know you're on hydroxyurea, please, there is nothing like I am pregnant by mistake. And as soon as you get to know that you are pregnant, you need to stop the hydroxyurea as soon as possible and get in touch with your clinician or your nurse.
Okay, so somebody is asking, how can I get hydroxyurea from the whole teaching hospital. You have to go to the sickle cell clinic. You have to be a patient there before they can assess you and know whether you can take hydroxyurea or not. Okay. Okay, somebody is asking, Koku, you came to help the Volta Regional Hospital to put together their sickle cell clinic. Okay. Somebody is asking, if I don't have SCD clinic at my institution or hospital, what do I do as a nurse? And who is responsible for creating SCD clinic?
So again, we hope that we can have a network of clinics, and then we can even remotely supervise the clinics that are in the region. And then I know a lot of pediatricians who are willing, even in other regions, to do that. So you just reach out to us, and then we help you set it up. And then when you have any issues, you can discuss with us. It's easily doable, because we know how difficult it is for patients to be moving, coming to the main hospitals and that. So that's the reason why we set it up at Hohoi, and then we are willing to do it other hospitals as well.
So just to add up to what Poku just said, so the minimum you need is a doctor. So if you have a pediatrician in your hospital, you need a nurse, and then you need a lab support. With these three people, your records is for the hospital already. So you need one dedicated doctor. If you're already running clinics in your facility, you can't block a time for sickle cell, and then you, the nurse, and then you need lab support. And like Oku said, we can have what we call the twinning. So you started the clinic, but you have something like a hospital that has a well-established sickle cell clinic that is overseeing the activities of your clinic. And Mary, just let me add this to it. The issue of why hydroxyurea is not accessible in certain places. I was part of the committee that the NHIS and the Ghana Health Service set up when we wanted to put hydroxyurea on NHIS. Now, the challenge is that there's a minimum requirement that you should have as a facility for you to be accredited to have hydroxyurea. So even hospitals here in Accra, it's not all of them that are accredited to have the NHIS hydroxyurea. Because if you don't monitor hydroxyurea, that is one. If the person prescribing the hydroxyurea does not have expertise, then hydroxyurea now becomes a dangerous drug. Because if the patient is taking the medication, you need to be able to monitor the labs, medication to make sure that it is not causing problems. So if in your facility you don't have lab support, and there are certain types of lab you should be able to do in your facility for you to be able to put your patient on hydroxyurea. So if you don't have that, it will be very difficult for anybody to bring hydroxyurea there. Secondly, you should have at least a specialist who has been trained to be able to prescribe it. Yes, the person may be a specialist, but if the specialist is an obstetrician, does he see children or patients with sickle cell disease? Is the person ready to take that added load on? Because you need that dedication. And you, the person prescribing, you should have in-depth knowledge into it to be able to identify when it is causing problems. So NHIS had a very strict criteria for accrediting facilities that could prescribe hydroxyurea. So you realize that a lot of the facilities are not accredited to have NHI. So depending, you may be attending a sickle cell clinic, all right, but your facility may not be accredited to give hydroxyurea on NHIs, or your hospital is not accredited to even prescribe hydroxyurea. So what we've been doing recently is that for the various hospitals that don't have hydroxyurea there, the clinicians refer the patient to a nearest regional hospital where they can get the hydroxyurea. And then you, the doctor there, you can be doing the follow-up on the labs and all that. And then the patient can assess the hydroxyurea at the institution every 3 months or on monthly basis. Otherwise, because your hospital is not accredited, the patient may be buying, and that makes it unfair because they may hear from other people that they are getting it on NHIS and they have to buy.
Okay, all right, thank you. So let's move on to the solutions, okay? So Koku mentioned a few, I think I will mention some few challenges, and Dr. Riafi, I think spoke about the availability, how available we can make hydroxyurea. And we also talked about the cost. I think Dr. Riafi made mention of that. Now, Koku, when it comes to knowledge, side effects, and also side effect, what can you say? What are some of the solutions to I mean this? Because somebody in the audience said that when she was put on hydroxyurea, she got dark lips. How can she reverse that? Okay, so how do we solve this? I think Diana too can come in if you want to.
What we know so far is that those side effects are short-lived. They are transient, so they're going to be there for a while and then they will disappear. in most of our patients, that's how it is, and they disappear. So you don't have, so far in our patient, you haven't seen any side effect that will be there for a longer time. What we are afraid of usually is when certain blood parameters go low, okay? And that's where we get worried. So as I said, there are only few patients that hydroxyurea does not work because of those reasons. If it happens, we have to stop it. But darkening of the lips or the nails or tightening of the hair, they just happen during a short period. I just have to wait, and then after some time, it will disappear.
What about knowledge, the knowledge aspect?
So
as clinicians, yeah. Continuous education, yeah.
Continuous education. There are a lot of training that's being done to empower doctors, nurses. And if you are attached to a sickle cell clinic, ideally, may we have education on daily basis or during clinic days. So as you are attending the clinic, you'll be learning from it.
Okay, but Koku, there are other places that they don't have a sickle cell clinic, but sickle cell patients go there. Yeah. I mean, they see. So how do we train those people too?
So a lot of trainings have happened during this year. Diana can speak to that because she's a trainer, and where they go to places to train nurses and doctors. So there are fundings now to train on blood issues in Ghana. So I think those hospitals can benefit from it as well. There's one we are organizing in August. So that's also one of those opportunities. But I want Diana to speak to it because she's a trainer in that.
Diana, right. briefly.
All right. So we have several avenues for training. Now there's a lot of online platforms where you can take models. And there's the World Continuous Education Alliance, WCEA, where we have put a lot of CPDs there on sickle cell disease, acute management, hydroxyurea, there are a lot of them. So just go on the net, download the WCEA app, and
can you type it? Can you type it in the questions and answers session?
So
when you are done,
I'll type in. So there are a lot of online courses that we have developed and put there on sickle cell disease. That is one. The pediatric nurse education program that is being done under the Ghana College of Nurses. In 2019, we did almost all the 10 regions. We trained nurses, we trained doctors. The Huju project also trained doctors and nurses. Every time they are ongoing. Currently, the World Childhood Cancer is also embarking on training in sickle cell. So what I entreat people is that go online. There are a lot of CPDs there. Now, because of the online programs, you don't need to travel all the way, but they are accessible. You can get knowledge there. And then people are around. We all trained. We had people that we passed through their hands. If you are tight somewhere, please pick a phone, call somebody. How can I help this patient? Sometimes we don't need to refer the patients hours and hours to come for help. Sometimes just a telephone conversation with a colleague, and then you can manage that patient there. So we are open, and then there are plenty of avenues for nurses, for doctors, for laboratory persons to get more information on sickle cell disease.
Okay, so Koku, when you were doing your presentation, most of the studies that you were speaking to, most of them were done outside Ghana. So when it comes to the solutions, do you think research we have to do more research in Ghana to really understand our patients and help them better?
So as you can see, I presented those studies because we haven't done some in Ghana, but those countries are not different from Ghana. And the polls that we have had here, and then the survey that we did before this webinar also show that our people and those people are the same. So the solutions will also be the same. So when it comes to drug availability, the drug is expensive. NHIS has taken is covering the issue. So if it is not effective in some places, I think we need to advocate more to ensure that it's available.
Okay, okay. Go ahead.
Because of cost, maybe it will also come at a cost to the taxpayer because government is paying. It does mean that. So if it's a cost, maybe in some countries like Tanzania, they have a law that those drugs that are very necessary, they will reduce the tax on it and becomes cheaper, and then people can actually buy. For instance, the tablet is not covered by health insurance, but the capsule is. So maybe government can consider reducing the tax so that a patient can afford. I know people with private insurance, they have access to it. Or again, as we mentioned, some of our pharmaceutical companies should find a way of producing generic hydroxyurea. In other countries, they have produced hydroxyurea, so our people can also do the same, right? And
okay, so Dr. Riafi, can we say that if government takes off all the taxes, hydroxyurea can be made available to the pharmacies, and the prices can go down? It doesn't have to be on NHIS, and patients can afford it?
Yeah, possibly is also another avenue we can exploit. And the moment, we only have the 500 mg capsule, the 100 mg tablet, 100 mg tablet on the APIs, not there. So if a child needs, how do you get it from the 500? It has to be prepared. So if we are able to take these taxes on the way of ensuring accessibility, we are likely to get the 100 and then and even the 500, well fixed on the NHIS, and everybody will be happy with it. Okay, thank you.
All right, thank you. Now, this is where advocacy is so important. So you are the president for the Sickle Cell Association chapter at the Ridge Hospital, right? So yes. What is the role of advocacy here? Okay, what can we advocate for as an association, right? As a sickle cell advocate, how do we make sure that patients have access? How do we make sure that the cost is low? So this is where advocacy is so important. So what can you say?
So first of all, during the period that we were advocating, and again, POF did a fantastic job to, make that possible. During that process, we one of the things that NHIS shared with us that we needed to increase our numbers of people on NHIS who have sickle cell disease. So the advocacy needed to start from there, to encourage more people to sign on to the NHIS program, so that, with the numbers, when we have an increased numbers, we can reduce the costs collectively. So that's the first step. That's where we need to encourage more people to go on NHIS to help us reduce the costs. Secondly, with the price fluctuations, one of the things that the deputy director of NHIS had shared with me was that, again, it was because some other pharmacies were bringing it into the system, and because we had a program with Novartis, which has drastically reduced the cost for us, we needed to encourage more people to access the Novartis, medication of hydroxyurea. So that was also one thing that we needed to work on and to advocate for within our facilities. And then thirdly, it's a matter of ensuring that people use hydroxyurea effectively. So, again, awareness. So awareness about, the medication being in existence, awareness about how to administer, but also, take it effectively. And I think that once we have all of those things in place, we will see, a cost reduction, which will also translate into better quality of life and care for all. But the NHIS is always, we have their ear, and they're always listening to our concerns and always taking that into, consideration. So for us, while we're advocating, we need to make sure that problems we're encountering, we make it available to them in a timely manner so that they can act on it. I can personally say that anytime I've had concerns from my association members, and I have, sent it to the deputy director, she's almost immediately gets back to me, and we're able to find a way to resolve the issue. So we definitely need to make sure that the concerns are being, passed on to them in a timely manner so that they can also do what they can do to help us.
Okay, so I want to add this. I was the CEO for the Global Alliance for Sickle Cell Disease Organization. And I remember during my tenure, I visited the Ministry of Health and I met one of the directors. And one thing that he said is, when it comes to people advocating for sickle cell, we are fragmented. We are not together. Why don't we form a federation? Why don't we form a coalition? So I think that is what we need. When we form a coalition, when we form a federation like others have done in Kenya, in Uganda, when we do that, we'll be able to champion a lot of things that we want for the sickle cell community. So I think in the advocacy community in Ghana, we should also think of that, coming together to advocate instead of being fragmented. Everybody's doing bits and bits. We can come together, and when we come together and we have a bigger fund, we can do much for the sickle cell community. So thank you so much, everybody. Our audience, they've been here for almost two hours and over. Thank you so much. That tells you how much this topic is so important to the community. Thank you so much, Dr. Amega Ahu. Thank you, Dr. Ebenezer Riafe. Thank you, Dinah. Thank you, Awo, and thank you, Elisa. Thank you so much for making time to be with us. We've been together since 3 p.m. Thank you so much for making time for this. We are very grateful, and we want to thank our audience too for coming and being with us. And we want to thank our sponsors. As I said, our biggest sponsor is Bank of Ghana, and then Novartis, then the Solar, Neutron Energy, then the Ghana Medical Association, then the Volta Regional Hospital. Thank you so much for making this possible, and all our collaborators, okay? St. Francis College of Education, St. Teresa's College of Education, the Nursing and Midwifery Training College of Hohoi. Then we have the Whole Teaching Hospital, and we have UHAS. UHAS is the main organizer. So thank you, everybody, for participating, and we'll have more activities coming up, and we will update you. Since we have your emails now, we are going to update you. Thank you so much. Koku, somebody wants to ask, what is the CPD point for this?
Yeah, so we don't know yet. We have to submit to it, and we'll be told how it depends on the duration and the content. So it will come with time. And I also want to apologize to those who have asked questions. We are trying, Diana and myself, to answer some of them, but we are not fast enough. So maybe if they are in my box, I'll be able to.
We will, and we'll post it on our Facebook account. We will answer it and post it on our Facebook account. So you have the opportunity to answer them, then we'll post it there. All right. So thank you so much. So from Hohoi, say bye-bye.
Bye-bye.
Bye-bye. Thank you so much. The panelists, please stay on. Thank you so much. Let me give you the host. I've done that.
Mary, we need a bit of time for people to drop off. So almost
Kwaku,
have dropped off.
no, Kwaku is going to block them so that.
Okay.
Kwaku.